So today I will be speaking on syndromic testing and antimicrobial stewardship. It's a vast topic, and I have a time of 1 hour. So I will try to cover as the key principles and key elements of diagnostic stewardship, antimicrobial stewardship, and syndromic testing. So uh, antimicrobial resistance is a silent killer pandemic going on. And in this fight against antimicrobial resistance, uh, antimicrobial stewardship, diagnostic stewardship, and infection control are the three prongs which will help us to deal with this global health issue of antimicrobial resistance. I repeat, nothing is isolated, neither antimicrobial stewardship, neither diagnostic stewardship or infection control. They are not three discrete elements, but they should be taken together as a comprehensive way to deal against antimicrobial resistance. It is said that microbiology is the driver or the basis for running the antimicrobial stewardship program. So the more emphasis will be on diagnostic stewardship in this fight against antimicrobial resistance, along with antimicrobial stewardship as well as infection control. So to proceed with the syndromic testing, which is the topic of today's session, let me first present here two cases here. The case report 1, a 60-year-old male patient presented with fever, productive red tinged cough since 2 days. In a history of bone marrow transplant, multiple myeloma, and chemotherapy. He is on tricyclic hemodialysis and central venous catheter. Past history of pneumonia and sepsis between chemotherapy sessions. The blood counts are nearly normal. The X-ray shows moderate infiltrates with mild pleural infusion. Empirical antibiotic therapy was started with meropenem and teicoplanin. When the multiplex pneumonia panel, I will describe here. It is a multiplex PCR. It's a PCR. There are panels available which runs on the principles of microarray also, wherein multiple primers and ligands are held together in one single test to detect different pathogens. I will describe this test in my next few slides. For time being, I'm mentioning here that multiplex pneumonia panel done from the sputum sample yielded para-influenza virus. Blood and sputum cultures were negative. Hence, empirical antibiotic therapy was stopped, seeing that multiplex pneumonia panel was yielded para-influenza virus. The patient was discharged after the total hospital stay of 5 days. He was afebrile with a good general condition after 5 days. 1 week follow-up discharge showed no signs of any acute infection. There was a residual dry cough and normal pulmonary auscultation. So this was the case report 1, wherein the multiplex pneumonia panel showed a para-influenza virus and the empirical antibiotic therapy was stopped and patient recovered well. The second case is the 65-year-old female patient presented with fever, dry cough, and nasal congestion since 2 days. Hypertension, poor weight, multiplex respiratory panel. Again, like we had a pneumonia panel for the case 1, here we did a multiplex respiratory panel from a nasopharyngeal swab. Since the female patient was, not cough was non-productive, it is a dry. So sputum was not available, hence nasopharyngeal swab was done, which yielded human rhinovirus or enterovirus. SARS and influenza antigen were negative. The clinical conditions were normal, or the lab test and the X-ray were not significant. The patient was started on treatment with NSAIDs. After 4 days, the patient was presented with dry cough, nasal congestion on OPD basis. She was afebrile. The multiplex pneumonia panel was again done from nasopharyngeal swab again, which yielded rhinovirus, enterovirus, as well as Moraxella catarrhalis at a count of 10^4 per ml, and Haemophilus influenza at a count of 10^4 copies per ml. The clinically examination was not remarkable. Chest CT ruled out any acute pneumonia. Antibiotics were not indicated. NSAIDs were continued, and the patient showed a clinical recovery after 3 days. 1 week follow-up was normal. Now, in the two cases, we see in the first case report 1, suspecting that there was a bacterial infection, the patient was started on an empirical antibiotic therapy. But when the multiplex pneumonia panel was done, the multiplex PCR panel was done for pneumonia from sputum, it yielded para-influenza virus, hence the antibiotic therapy was stopped, and the patient had a regular clinical course of like a viral infection. But in the second case, the panel was done for respiratory panel, and the sample that was taken was incorrect. That is a nasopharyngeal swab. So therein is the importance of diagnostics, the principles of diagnostic stewardship. That is correct test, correct sample should be taken for the correct test. Respiratory panel was done is right, but the samples but the samples should have been different. So that's the importance of pneumonia multiplex panels of PCR, such as the respiratory panel and pneumonia panel. So we'll cover up these elements or the importance of this panel as we move ahead to the further slides, where we get more detailed idea of about how pneumonia panel, how such multiplex PCR panels such as respiratory or pneumonia panels is of significance in the diagnosis and the correct treatment of the patients. Herein also I would like to highlight, though bacterial species were identified, such as Moraxella and Haemophilus, in the colony count of 10⁴, that it will mislead the clinicians, because a pneumonia panel was done, and for a pneumonia panel the correct sample is sputum instead of a nasopharyngeal swab. So correct sample should have been taken for the pneumonia panel, which will yield the correct pathogen. So in this case, if the clinician would have started on antibiotics, it would have been added to the extra cost of the patient, as well as also adding to the resistance. So, fortunately, in this case, the patient was not started on antibiotics, realizing that Moraxella and Haemophilus were colonizers. So in this way, correct interpretation of the microbiology test or the molecular diagnostic test should be done for correct treatment of the patient. So let us understand what is syndromic testing now. So we have seen these two cases. That's the base for the today's session. We now see in detail about principles of diagnostic stewardship, focusing more on syndromic testing. Syndromic testing is the process of using one test to simultaneously target multiple pathogens with overlapping signs and symptoms. Symptoms is what the patient presents, for example, fever, chills, and rigors. Signs is what the clinician observes, that is temperature, pulse, BP, respiratory rate. So signs and syndromes taken together forms a syndrome. And syndromic testing is process of using one single test to simultaneously target multiple pathogens. The multiple pathogens would include colonizers as well as pathogens. And from the list of these organisms, then the clinicians identifies the correct pathogens with the correct interpretation to identify the most probable pathogen causing that syndrome. Syndromic testing guides the clinicians in the diagnosis of many infectious clinical syndromes. Again, application of diagnostic stewardship maximizes the benefits of syndromic panels. It often presents with a very vague signs and symptoms. Often we've seen in the OPD settings with upper respiratory tract infections, which could be because of rhinitis, sinusitis, ear and pharyngitis. Mostly are viral. Routine testing is not required. Therein, syndromic testing is a benefit. A lot of diagnostic test tools are available, which are time-consuming, labor-intensive, technical complex, which gives a low yield. Also, the microbial tests are more expensive. Cost is a major limiting factor. Also, most of the PCR test or molecular diagnostic test has very limited coverage, confounded by overlapping symptomology, and need to order multiple tests at one time for different samples to identify this pathogen. Also, there are at many times at some places there is unavailability of test. Therein lies the role of syndromic testings or syndromic panels. Now, if we compare the traditional versus the syndromic testing, the traditional testing, we from one sample we order multiple tests, and that result takes hours to days, and there are multiple individual results in separate reports, which adds to the longer length of stay of the patients. While in syndromic testing, one single sample, there is a one comprehensive test. It takes about less than an hour, and multiple results are reported in one single paper, which improves the patient's management, resulting in a shorter length of stay, morbidity, and mortality. So that's the difference between traditional testing and syndromic testing. So why to use syndromic approach? To detect the most relevant pathogens involved in the disease. If we go for single individual tests, it is always confusing. So when we take a syndromic panel, we could, depending on the colony count and depending upon the syndrome analysis, we could detect the most relevant pathogens involved in the syndrome. It helps us to detect the unsuspected pathogens too, and the most relevant pathogens too. It helps to detect the additional underdiagnosed pathogens. It detects the co-infections, helps the clinicians in their clinical decisions about patient management, and generates cost savings at the hospital level too. What does the healthcare facilities require? One is antimicrobial stewardship, infection control, and diagnosis stewardship, which includes better and faster reports, actionable results, reliable results, better diagnostic tools, and affordable diagnostic tests. Let us see the scheme of the antibiotic therapy. A suspected patient presents with an infection, then we order for the microbiological samples for cultures and stains. We order for biomarkers, rapid tests, card test, ELISA test. Then, based on the syndrome, an empirical antibiotic regimen is ordered, employing a combination of agents targeting the multi-drug resistant organisms. Then monitoring of the clinical response to the treatment, such as temperature or the lab test and hemodynamic parameters. Then, based on the microbiological identification of the pathogen, if there is the pathogen is identified and only viruses are identified, we consider discontinuation of antibiotics. If there is a significant clinical improvement after 40 to 96 hours of the treatment, and based on the positive microbiological results, we de-escalate the empirical antibiotics based on microbiological results. We discontinue the antibiotics after 7 to 10 days of the course based on the infecting pathogens and as per guidelines. If there is no significant clinical improvement, we review the doses of antibiotics to optimize the drug levels, we reculture and consider for some non-infectious causes of fever or inflammation. If the microbial identification is negative and there is no significant clinical improvement, we again review the doses of antibiotics and the therapy. But there is a significant clinical improvement of the patient in spite of a negative microbiological results, we consider discontinuation of the antibiotics or limit the course of the therapy. So that's the course of the antibiotic therapy. And this is how diagnostic stewardship and antimicrobial stewardship are interrelated. When a patient presents, when a patient is clinically evaluated, the clinician orders for the right test for the right patient using the right sample at the right time. That is the 4 R's of the diagnostic stewardship. And based on the microbial results, the right antimicrobial is ordered at the right time for the right patient to the right dosage, duration, frequency, using the right interpretation of the diagnostic test. So this is how diagnostic stewardship and antimicrobial stewardship are interrelated along with infection control. The diagnostic stewardship principles are further affected by inappropriate use or interpretation of microbiology. So microbiology results needs to be correctly interpreted. Lack of microbiology confirmed diagnosis is an issue in the management of patient therapy. Then failure to submit appropriate correct samples for the cultures. We'll address these issues in my further slides. But mentioning here that some of the issues in the microbiological testings, that is failure to submit the right specimens, failure to interpret the microbiology results, lack of confirmed diagnosis, the misuse of the microbiology resources, and over reliance on empirical coverage regardless of the microbiological results. So I repeat, syndromic testing means one sample which gives a one comprehensive test. It takes about 1 hour for results, and multiple results are reported in one report. It provides a better patient management, provides more timely and effective treatment, limits the use of unnecessary antibiotics, as we have seen from the case 1 and case 2, prevents the secondary spread of the infection, and reduces the cost of unnecessary testings. While conventional testings are cheaper, for syndromic testings, one sample gives many results. There is an understanding of the epidemiological surveillance. It has a greater sensitivity and specificity. Broader range of pathogens are covered, and also since being it's a multiplex PCR, it reduces hands-on time and laboratory time too. The key concept of syndromic approach includes it predicts the possible pathogens, usually from the natural flora of the system or the published literature. We identify the primary, or it helps us the clinicians to identify the primary organ involved in the syndrome. Then, based on the host factors such as age and immunosuppression, or the exposure to the healthcare pathogens, and any specific interventions, the choice of the empirical therapy is determined. Based on the potential list of pathogens, the risk of multi-drug resistant organisms, and then single or multiple antibiotics to cover the pathogens. So when we see about the primary organ system involved, for example, if the CNS and the brain infections such as brain abscess, the potential pathogens in usual settings are the oral flora, the sinus infections, while the potential pathogens in specific conditions such as trauma or post-op includes gram-negative bacilli, MRSA, or fungi. The antibiotics that could cover these pathogens include ceftriaxone or metronidazole or meropenem and others. Similarly, if it is acute respiratory tract infection, it is gram-positive cocci and viruses, Haemophilus influenza, atypical organisms, and potential pathogen specific conditions such as immunosuppression includes PCB, pneumonia, pneumoniae, healthcare associated pneumonia from gram-negative bacilli. Then the antibiotics that could cover these pathogens include ceftriaxone, azithromycin, cotrimoxazole, and others. So that's the key principle of syndromic testing. To summarize, the syndromic-based antibiotic prescription consists of 4 elements: make, consider, review, and finalize. In a make, we make a syndromic diagnosis, that is organ system-wise diagnosis. Usually, sometimes we take it as an occult sepsis or tropical sepsis, but an organ system diagnosis is made from in a syndromic testing. Then we consider the pathogens involved, the most probable relevant pathogens involved in the syndrome, and based on the host status such as immunocompetent or immunosuppressed, age, specific procedure carried on. Then we review the local antibiogram. Antibiogram, that is the pattern of the organisms or the pathogens prevalent in that healthcare setting and their sensitivity to different antimicrobials. So we review the local antibiogram, and based on ICMR guidelines, we understand the most prominent pathogens responsible for the syndrome. Then they finalize the antimicrobial combination that could be effective against those pathogens involved or it is detected through that syndrome testing. So what factors should we consider while antimicrobial prescription? The indications for use, that is prophylactic, empirical, or definitive. Then the route of administration, dosage, duration, the frequency, the side effects, the allergic effects too. Then for antibiotic prescription, we should see whether the particular antimicrobial is considered as in a reserved list of as per the hospital policy, like colistin, polymyxin, TGSec, and others. Then we should consider whether drug combinations would be effective, cost effective, as well as effective against a particular syndrome. Whether it is justified by the ID physician or a microbiologist, whether cultural sensitivity is performed, the result is available for the antimicrobial prescription, and based on standard guidelines like ICMR guidelines, antimicrobial prescription should be done. We have ICMR guidelines for common syndromes, which gives guidelines which explains about the management of different syndromes such as skin and soft tissue infection, bone infection, CNS infection, and others. The present ICMR 2022 guidelines mentions about the details of syndromic management of the patient. For example, outpatients without comorbidities, the preferred drug is comoxazole. The other alternative available is macrolide, and with comments such as beta-lactam is preferred over the macrolide due to the high prevalence of macrolide and others. So similarly, the guidelines are available in the ICMR 22 guideline reference. The participant can refer to those guidelines for the patient therapy. Also, the ICMR has recently released a national antibiogram too. As I mentioned, we mentioned in a few slides before, the antibiogram should be referred to determine the most relevant pathogens based on syndromic testing. What is an antibiogram? This is a picture of an antibiogram. Antibiogram represents the different pathogens available, prevalent in that hospital or the healthcare facility, and from different clinical samples such as blood, urine, respiratory tract samples, CSF, and other samples. Such antibiograms are available are available from different zones of the country as per the recent ICMR report for different organisms and against different antimicrobials. These are the few references I will share herein. I will make this presentation available to all. I will share this with the Melap team, and you can refer to this references that I use for my presentation. One is syndromic testing in infectious diseases, from diagnostic stewardship to antimicrobial stewardship. Then you can refer, the participant can refer to the sampling the guidelines from sampling to reporting, standardization for quality and research, which is in BMC publication, wherein there are guidelines or explanation given for when should a specimen be collected for bacterial culture, what kind of specimens should be selected, and how should the specimens should be collected, stored, and transported to the laboratory for testing. Then we have microbiology criteria for reporting to that can be referred this is microbiology comments help given in the reports guide the clinicians for right interpretation of the reports. This is some more references. Now, another use of comments in the clinical microbiology is very important. Like, for example, in the microbiology results, we see the cultural sensitive reports. On one column, we see the antibiotics, and in another column, we see the sensitive and resistant with the MIC given. But the MIC, I will advise the clinical microbiologists to report along with the MICs the clinical breakpoints too. The ratio of the clinical breakpoints to the MICs, that is the efficacy ratio, or the breakpoint to MIC quotient, will help the clinician to correctly to select the most appropriate antibiotic for the particular syndrome. So the comments should include the sample collection should include comments such as more than 3 isolates from an urine culture is isolated. So advised clean urine sample, or advanced strict hand hygiene and contact precautions. If inherent organisms such as Proteus mirabilis, which is inherently resistant to nitrofuran and coalition, is reported, then the comments should be there in the reports. If Staphylococcus is isolated in urine, the comment should include that kindly look for an upper tract urinary pathology or advise a blood culture, and similar such other comments should be included in the microbiology reports for guidance of the clinicians. So these are the few principles in the pre-analytic and analytic and the post-analytic pages. The principles should be employed. Pre-analytic means before testing the sample, that test only if the clinical presentation is consistent. Collect the sample only if the clinical presentation is consistent with that infectious etiology. For example, urine cultures, test only when symptoms suggest urinary tract infection, or if asymptomatic, then if it is concordant with the guidelines such as urologic surgery, pregnancy, or obstruction, and others. Similarly, in the pre-analytic phase, also pay attention to sample collection, storage, and transport to optimize the yield and reduce the contamination. For example, in UTI, use aseptic technique. Use a mid-stream clean catch urine sample after peritoneal cleansing. Often it is seen in the blood cultures, we get a single bottle of aerobic, but it is recommended that we should collect 2 sets of blood culture bottles, like aerobic and anaerobic bottle from one prick, and aerobic and anaerobic bottle from the another prick, say from other hand. That would increase the yield of the blood cultures. Similarly, in the analytical phase, the principle that should be employed should include use adjunctive lab test to distinguish the colonization from the infection. The microbiologist should avoid reporting colonizers in the microbiology report, and they should use some adjunctive test to distinguish colonization from infection, and efforts should be made to report only the infective pathogens. Only perform urine culture if pyuria is present, that is pus cells are significant. And in the post-analytic phase, report results in a format that guides the clinicians for the appropriate practice. Takes the interpreting comments or the results, such as multiple organisms present, no pyuria, culture not performed, and other such comments. Selective reporting should be done for antimicrobials. So that were few of the principles in the pre-analytic, analytic, and post-analytic that should be followed in the microbiology testing to guide the clinicians for appropriate rational practice. These are some of more references that the participant could refer for diagnosis principles. Appropriate practical, for example, urine culture reports, I repeat again, inform the clinicians that even high colony count, such as 1 lakh colony count per ml, may not represent the true infection in absence of signs and symptoms. Nudge the clinicians to not treat asymptomatic bacteria. Nudge the clinicians to not treat mixed flora. Differentiate the typical uropathogens versus contaminants. Withhold the urine results when there are more than 2 organisms isolated. Preferentially report only the IDSA recommended antibiotics or the CLSI recommended antibiotics. Withhold the fluoroquinolone susceptibilities unless there is a resistance to preferred oral antibiotics. Then examples of role clinical microbiologists can play within an AMS program and within an AMS team include advice to the clinicians regarding infection control, infection management, such as diagnosis, treatment, and prevention, recommendation for collect sampling, storage, and transport, timely and accurate microbiology results. For example, CSF samples, most of the time the CSF samples are collected in a sterile container, and it is transported to the microbiology lab. The morning sample reaches by afternoon and is processed in the evening. CSF samples, if it's collected in a packed bottles, the food culture bottles, it increases the yield of the pathogens from such a precious sample such as CSF. CSF we often suspect fastidious organisms such as Streptococcus, Haemophilus, and Neisseria. These are fastidious organisms. As exposed to the air, they become non-viable, and there is a poor yield. So efforts should be made to culture the sample immediately as possible, as collected or transported in a fluid culture bottle at a room temperature for immediate processing. So we'll go to the syndromes and see how our panels could help us for the patient therapy. As said before, the patient F1 present with upper respiratory tract infection may be rhinitis, sinus, ear infection, pharyngitis, and others. Mostly they are viral. When to suspect bacterial sinusitis and otitis media? The presence of any one of these will help us to suspect bacterial sinusitis or otitis media. One is persistent signs and symptoms lasting more than 10 days, high fever and purulent nasal discharge lasting for at least 3 to 4 consecutive days at the beginning of the illness, then double sickening, that is repeated episodes of fever, then worsening the signs and symptoms characterized by new onset of fever, nasal, headache, or increase in the nasal discharge after 5 to 6 days, which was initially improving. So that is double sickening. So then we suspect bacterial sinusitis or otitis media. Routine lab assessment is not required in such cases. Clinical management suffices unless there is an intractable, recurrent, or chronic rhinosinusitis. So when do you suspect fungal sinusitis? Symptoms worsen or fails to improve after initial antibiotic therapy, and even after broadening the broader coverage, or switch to different antimicrobial class. Then severe, rapidly progressive disease in immunocompromised diabetic patients with ketoacidosis, transplant recipients, patients with hemorrhagic malignancy, and others. Even for mucormycosis, we see a black necrotic nature of the nasal cavity and turbinates, facial lesions, and necrotic lesions of the hard palate. Then we suspect fungal sinusitis. So these are a few clues which can help us to differentiate between bacterial and viral infections. One is in bacterial, we see sudden onset of symptoms with sore throat, fever, headache, nausea, inflammation, and exposure to streptococcal infection. Exposure to streptococcal infection. But in viral, we see conjunctivitis, coryza, cough, diarrhea, and discrete ulcerative lesions. So these are few of the clues to differentiate bacterial and viral infection. Also, we have some rapid biomarkers such as procalcitonin and others which will help us to add OPD settings to differentiate bacterial and viral. Then this is the severity score, modified central score for bacterial pharyngitis, which includes temperature, swollen lymph nodes, cellular swelling, and based on age, there are points grading out of points. So based on the central score, say a score of less than 0, and less than 1, there is no testing required. The score of 2 and 3, group A streptococcus immunochromatography test is required. If positive, treat, and if it is negative, then send the samples for culture. If the score is more than 4, then treat empirically with A1 beta or beta cultures. So the same score is used for the risk of the streptococcal infection and for the accordingly for the management. There are rapidly available point of care tests available for upper RTI, such as for COVID-19, we have antigen testings. If it is negative, but patient is symptomatic, then send for RT-PCR. For influenza, we have PCR, rapid immunochromatography test. And for group A streptococci, testing is recommended based on center score and culture if test is negative. For the respiratory panel, we have one test which is about 22 targets and with a time period of 45 minutes. Please excuse me. I will be using respiratory panels and pneumonia panels and GI panels, as gastroenterology panels and meningitis panel, because presently these are the panels that are presently widely available and widely used. So we have presently the respiratory panel. The principle of this test is multiplex PCR or microarray. Is a one test which details about 22 targets within a span of 45 minutes. The different viruses that could be detected from this respiratory panel includes adenovirus, coronavirus, different species of coronavirus, SARS-2 virus, human metapneumovirus, and human rhinovirus, enterovirus, influenza, parainfluenza, and bacteria such as Bordetella, Chlamydia, and Mycoplasma. The sample type for respiratory panel is nasopharyngeal swab. And the sample type for the pneumonia panel, which I'll be mentioning in the next slide, is sputum sample. But I repeat, respiratory panel, the sample is nasopharyngeal swab, sample volume of 300 microliter, and it has a sensitivity of 97% sensitivity and 99% specificity. Respiratory panel as compared to traditional testing, have observed when have been observed to in ICU days. For example, the panel that I'm referring to is the BioFer respiratory panel, wherein before BioFer adoption, the mean ICU days was about 9.2 days, while after BioFer adoption, it was about 6.2 days. The duration of the antibiotic use was about 3.2 days, but after usage of the panel, the duration reduced to 2.7 days. So these panels help us to reduce the mean ICU days as well as the duration of the antibiotic use. It can dramatically reduce the time to diagnosis compared to traditional test methods. When before adoption of the panels, it was about 25 hours. When after this panel adoption, the uh, duration reduced to 3.2 hours. There was an 84% drop in the turnaround time of the duration. Overall performance of the respiratory panels is about 97% sensitivity and 99% specificity. Now, who should get this tested with the respiratory panel? It should be used for high-risk patient groups such as young infants, elderly patients, patients with comorbidities, and immunocompromised patients. So one of this principle of diagnostic stewardship that it should be cost effective. So considering those principles, it should be reserved only for high-risk patient groups. So that is of the upper RTI. For lower RTI, which when the patient presents with cough with or without expectoration, shortness of the breath, pleuritic chest pain with high fever, chills, chest pain, or difficulty in rapid breathing with less than 3 weeks duration, we consider as either a community-acquired pneumonia or healthcare associated pneumonia. But for while cough, fever, and symptoms more than 3 weeks duration, the suspicion goes more for tuberculosis. There are different causes of community pneumonia, which include bacterial causes, which include Streptococcus, Klebsiella, Haemophilus, Staphylococcus, and others. Viral causes include influenza, SARS-CoV-2, parainfluenza, respiratory sensitive virus, and others. Atypical, the word is a misnomer. But the atypical word is commonly used. The atypical pathogens are chlamydia, legionella, and chlamydia pneumonia, legionella pneumophila, and mycoplasma pneumonia. It is important to note that Mycobacterium tuberculosis is also an important pathogen which can be present at community-acquired pneumonia in TB endemic countries like India. Now, let's say the management of the community-acquired pneumonia. We collected an nasopharyngeal swab for SARS-CoV-2. If it is positive, we start with the management of SARS-CoV-2. But if it is negative and it is non-severe, we consider we see the risk factors for MDR pathogen or the multi-drug-resistant organisms or comorbidities. If it is negative, then we start on treatment with coamiciclovir or doxycycline or ceftriaxone or Melap. But the risk factors are present, and if it is hospitalized, when we go for ceftobiprole or ceftriaxone or linezolid or vancomycin plus peptides or meropenem or impenem or civipenem. I won't go to the details of the antibiotic therapy. It is just sharing the flow chart for time being. For if the community-acquired pneumonia, the nasopharyngeal swab for SARS-CoV is negative, but the patient is severe, we advise for the urine antigen positive. We advise for the urinary antigen test, and if it is positive for Legionella or Streptococcus pneumonia, we start the antibiotic therapy with beta-lactam or macrolide or levofloxacin. But if it is negative for Legionella or Streptococcus pneumonia and the risk factors for MDR are not present, we go for beta-lactam plus macrolide. But if the risk factor for MDR is present, we advise for rapid multiplex PCR, that is the pneumonia panel, and with no targets are detected, we put the patient on beta-lactam or macrolide. But more than one or more targets are detected, and based on carbapenem detection. Now on the carbapenem detection, we will see towards the end of the session. And based on carbapenem detection, again, if it is positive and carbapenem test is positive, and if it is MBL is detected or NDM, VIM or AIMP detected, then we start on the ceftriaxone, iobactam or aztreonam or cefiderocol or colistin and others. But KPC or oxoferritin, then we start off set of the iobactam or mirabactam and others. But the carbapenem detection negative and MEC gene or MEC gene is detected, which indicates MRSA. If it is positive, we start on ceftobiprole or ceftaroline or linezolid or vancomycin. If it is negative, then treat according to pathogen identity. Commonly, the mistakes with that we often see that pneumonia on the basis of hearing crackles. However, we mention here crackers indicate heart failure or fibrosis, but not pneumonia, especially in the elderly. And this is a summary of the commonly used criteria for risk stratification of community acquired pneumonia. That's CURB 65 score or the ATS IDS criteria. CURB 65 score, which includes confusion, urea concentration or respiratory rate, and lower BP and age of 65 more. So based on the CURB 65 score and the pneumonia severity score is judged. A CURB 65 score of 0 to 1 can often be discharged, but the score of 2 usually require observation, and score of more than 3 requires admission to hospital. The common causes of pneumonia include Staph aureus, Streptococcus pneumonia, Haemophilus microbiota pneumonia, and others. If history of COPD is present, it also includes Pseudomonas aeruginosa. If it is a history of aspiration, then it's anaerobes, which includes bacteroids and Fusobacterium. If it is zoonotic, mostly the suspected pathogen is Chlamydia psittaci. And if it is empyema, it includes it indicates organisms like Staph aureus, Streptococcus pneumoniae, and Streptococcus anginosus. Two conditions which often misused and not covered by the normal antibiotics includes tuberculosis and pneumocystis pneumonia. Often for the investigating CAP, for investigating CAP, no testing is recommended in community acquired pneumonia patients being treated in OPD. For chest X-ray is done for all patients. Chest X-ray is not recommended as a follow-up test if symptoms have resolved within 7 days. Routine test is done like CBC, TLC, and KFT. Sputum, gram stain culture, or blood cultures are advised for severe community acquired pneumonia, patient being empirically tested for MRSA, patient previously infected with MRSA, patients who are hospitalized. For them, sputum, gram stain, or culture or blood cultures are advised. Investigation in community acquired pneumonia, no testing is recommended in community acquired pneumonia if the patient is being treated in OPD. For influenza testing during periods of high influenza activity, then nucleic acid amplification test is advised. Serum procalcitonin level is done only for de-escalation or stopping the antimicrobials. However, it is not recommended to determine the need for initial antimicrobial therapy. For investigations in CAP also includes tests like molecular assay, which is which is not routinely recommended for opportunity pathogens in immunocompromised patients to investigation CAP is advised. For management of community acquired pneumonia, the most based on the most causative organisms, the empirical antibiotics are includes amoxicillin and amoxicillin clavulinate and ceftriaxone and others. The alternative antibiotics include peptides, imipenem, ceftriaxone, sulbactam, and comments include if MRSA is concerned, then add linezolid, or if atypical pneumonia is suspected, doxycycline is recommended. For the lower respiratory specimen, sputum is the commonest corrected specimen. We have seen in the case 2, the nasopharyngeal swab was incorrectly corrected. But however, for the lower respiratory samples, sputum is the most common corrected specimen and the correct sample. It is acceptable only for microscopy and culture, only if thick, cloudy, and yellow, or green, or white in color, and the neutrophil to epithelial cell count is more than 2:1. Endotracheal aspirate in patients on ventilator and those who cannot export sputum is collected. The other lower respiratory samples include bowel fluid, mini bowel, lung tissue, and protected bronchial brushings. Again, we use this Bartlett score to determine whether the sputum sample collected is significant or not. If the WBC count from the sputum sample is more than 25 and the epithelial cell count is less than 9, then the sputum sample is significant for testing. However, if the WBC count is less than 9 and the epithelial count is more than 25, the sputum sample is rejected for testings. It indicates colonization or contamination, and it is not an infective sample. The respiratory culture should be transported in correct containers. Place the nozzle of the throat swab in appropriate transport medium such as Stewart's medium or Amis transport medium, and this should be immediately transported in the appropriate container to the microbiology testing lab for testing. Refrigerate if a delay of more than 1 hour is anticipated for fastidious organisms such as Haemophilus influenzae. If a bottle of is suspected, then specimen should be directly inoculated in culture media. Now for the low respiratory tract sample, we have a pneumonia panel, which runs on the principles of microarray or multiplex PCR. For the present pneumonia panel available yields about 34 targets within a span of about 1 hour. The 34 targets includes bacteria like Acinetobacter, Enterobacter, E. coli, Klebsiella, Moraxella, Pseudomonas, Cerasias, Staph, and Strep 2. While the atypical bacteria includes Chlamydia, Legionella, Pneumophila, Mycoplasma pneumonia. There are a list of other viruses that are detected from this pneumonia panel, as well as antimicrobial resistance genes such as carbapenemase, IMP, KPC, NDM, OXA, and others. The sample type for pneumonia panel includes sputum with a volume of about 200 microliter, and it has a sensitivity of about 96% and specificity of 98%. Pneumonia pathogens have been observed that it detects bacteria in more than 50% of the cases. The pneumonia panel is a diagnostic aid and should be used only in conjunction with clinical and laboratory findings. Antibiotic adjustment have been done using pneumonia panel in 68% of the cases. The average antibiotic interventions was over 1.48 using a pneumonia panel. Antimicrobial stewardship was more effective with using such panels such as the respiratory panel and pneumonia panel. Up to 50% of the patients could have been de-escalated based on using the pneumonia panel. So this is one of the reference I am sharing here, wherein it was observed that a high rate of secondary infections in COVID-19 patients were reported, which highlights the importance of antimicrobial stewardship program focusing on more optimal selection of empirical treatment and rapid de-escalation based on culture reports. Now we have seen about the respiratory syndrome, upper respiratory tract infections and lower respiratory tract infections. Let's move to CNS infections. There are multiple causes of CNS infections such as bacterial and viral in acute cases as well as in chronic cases, along with parasitic and fungal infection causes. For encephalitis, we have viral, parasitic, and bacterial. For encephalopathy, we have cerebral malaria, flu viral diseases. Space occupant lesions include brain abscess, empyema, epidural abscess. There are multiple investigation tests available for those for this infective agents. Like for example, for acute bacterial, we have Gram-Chain and CSF culture. Then meningitis panel. Then for acute viral, it is HSV, herpes simplex virus, varicella zoster virus, PCR in immunocompetent patients, arbovirus and entovirus based on clinical presentation. Then for subacute cases, we have AB staining, Indying, Cryptococcus, Mycobacterium culture, and gene expert. For immunocompromised or HIV positive patients, we have cytomegalovirus, Epstein-Barr virus, varicella zoster virus, Toxoplasma gondii, Listeria, and Cryptococcus. Now, which test for the other body fluids such as blood cultures, 2 to 4 blood culture sets are advised. For urine, it is pneumococcal antigen. For serology testing for CNS infection includes malaria antigen or smear for malaria parasites, or IgM antibody for the Japanese encephalitis, scrub typhus, dengue, chikungunya, Zika, and others. PCR test includes dengue, chikungunya, leptospirosis, rickettsia. Respiratory specimens include testing such as PCR for respiratory virus, mycoplasma, skin biopsy, knuckle skin biopsy for rabies. We do immunofluorescence staining. Then from stools, we do PCR for enterovirus. So this is what we see in the clinical CSF examination to differentiate bacterial, viral, tuberculosis, and fungal, wherein we use the elements of the color, cells, differential counts such as neutrophils and lymphocytes to differentiate between bacterial, viral, and tuberculosis causes. Do not refer to the sputum do not refer to the CSF samples, which tends to kill the phagocytic organisms such as Streptococcus or Haemophilus or Neisseria, as said before. If not rapidly processed, CSF should be incubated at room temperature. For viral studies, it can be refrigerated for 24 hours or frozen at -70 degrees if longer delays are anticipated. So there are a number of causes for CNS infections. The slides shows about the empirical antibiotics, the alternative antibiotics, and the comments required for analyzing the CNS infections. Now for the meningitis panel, for the meningitis infection includes from a single test, it can detect about 14 targets with around a time span of about 1 hour. The different bacterial targets that is detected from the meningitis panel include E. coli, Listeria, Neisseria, Streptococcus, which are the commonest bacterial causes. Also includes viruses such as cytomegalovirus, enterovirus, and others, and yeast like Cryptococcus. The sample type is CSF sample with an amount of about 200 microliter, and it has a sensitivity of about 94% and 99% specificity. Now, who should get tested for meningitis panel? It includes a group of patients such as young infants, elderly patients, travelers, immunocompromised patients, adolescents, and children and adults. It has been observed that it improves the times to diagnostic results, and a rapid test can reduce the length of stay and the duration of antibiotics. Has been concluded from using a meningitis panel. So that was about the CNS infections. Let's move to acute febrile illness. Fever, I will mention here, any increase about normal body temperature is not fever. Wait and watch till 100 degree Fahrenheit or 38 degrees Celsius. The definition of fever is mentioned in the slide. Any increase in temperature of more than 1.1 degrees Celsius or the baseline temperature is called as fever. Now, for acute febrile illness for less than 3 weeks, it's mentioned fever up to 3 days without the red flag signs, no need to investigate. Fever with localized signs, investigate about the clinical clues. Fever without localized signs, never once said, do a routine workup. And febrile illness more than 3 weeks, and advanced workup is suggested. So this is a chart of how to investigate for acute febrile illness. Other features suggest of sepsis, when there is collapse, cyanosis, and others. Resuscitation or urgent referral to hospital is advised. Appropriate investigation and culture samples is advised. But if there is no feature suggest of sepsis, based on the localized features on organ-specific appropriate investigation and management is advised. If there is no localizing features, an acute undifferentiated febrile illness is considered, and based on the pattern of fever, either a malaria testing is done or non-malarial testing is done or COVID SARS-CoV testing is done. Let's see about let's learn about sepsis. The current guidelines mention about sepsis 3 guidelines. The previous version about sepsis 1 and 2. Sepsis is a complex syndrome of physiological and pathological abnormalities resulting from infection. It is a life-threatening organ disinfection due to dysregulated immune response. SOFA score is often used, which is sepsis-related organ failure assessment score. 0.2 points or more indicates seriousness of the sepsis infection. Sepsis on the basis of suspicion of infection, the probability is very low. 30 to 40% of the patients with sepsis are of non-infectious etiology. There are many conditions which can indicate sepsis, such as cardiac causes, CNS diseases, autoimmune, pulmonary, drugs, endocrine, and others. So first score is used to indicate sepsis categories such as sepsis, severe sepsis, and sepsis shock. Other investigating tests for febrile illness without localizing signs include hemogram, blood sugar, CRP, rapid point of care test, then blood culture test, urine analysis, serology testing, imaging, and others. Fever with sepsis in addition should include serum lactate, creatine kinase, coagulation parameters. For fever of unknown origin, that is fever more than 3 weeks, no known etiology cause, then in an immunocompromised state, then we suspect of SLE, which contributes about 22% of the causes, then infection, malignancy, and then other miscellaneous causes. How to do what is the diagnostics of elements for such cases? Basic investigations, malaria parasite, blood cultures, and microscopy. For infection, neoplasm, and non-infectious inflammatory disorder, we have multiple tests based on the signs and symptoms. For cough, it is sputum AB. And CT, radiology guided procedures. For headache, it is CT or MRI or CSF studies, including cultures. For diarrhea, it is stool, occult blood, stool parasites, CT abdomen. And for neoplasm, it is bone marrow biopsy, lymph node biopsy, CT abdomen or thorax to look for any nodes. And for non-infectious inflammatory disorders, include collagen vascular disease workup, classified into SLE or vasculitis or sarcoidosis. So that was about fever of unknown origin. For the most common test done is blood cultures, and it depends on the patient's selection. Like major criteria for the selection of patient of blood culture includes suspected endocarditis, temperature, and indwelling catheters. Other minor criteria include temperature, age, chills, vomiting, hypotension, neutrophils, and others. There is a SAPRO score available. If it is more than 4, then there is a 90% sensitivity alone. If it is more than 4 plus, the procalcitonin is higher, then sensitivity is 98%. So that was one of the factor for blood culture at patient selection. Other is specimens, asepsis, skin and bottle, sets of bottle, volume of the blood for culture, the number of draws, the timing between draws, and others. If you see the blood culture volume, it will be about 10 to 20 ml for adults. It should be 1 to 5 ml for children, and for minors it's half to 1 ml. If the volume of blood is inadequate for the two bottles, then aerobic bottle should be inoculated first. The number of drops should be 2 to 4 sets by separate mini pinches, and timing between the drops should be less than 1 hour. So each set should consist of one aerobic and one anaerobic bottle. Cultures from all sides should be done within 15 minutes. For multi-lumen catheters, obtain blood culture from distal lumen whenever possible. Collect one set of blood culture from a peripheral side and one set from an indwelling line such as arterial central line or PICC or dialysis. Do not send the catheter tips after catheter removal for culture. If benefit is not possible, obtain 2 draws from single lumen catheter or draws from separate lumens of catheter. From a central venous catheter, blood should be collected using a push and pull method. So similarly, we have for blood culture, we have a sepsis panel or a blood culture panel, which detects 43 targets around the time of 1 hour, which include different bacterial and fungal organisms as well as antimicrobial resistance genes. The sample type is blood with a sample volume of 200 microliter and with a sensitivity of 98% and specificity of 99%. Using a blood culture panel has been observed to reduce the duration of the antibiotics and the patient stay in the hospital. Similarly, we have GI infections, which include wherein diarrhea includes passes of more than 3 loose stools or per day or more than what is usual for a person. Then we see it's an acute diarrhea if it is a duration less than 7 days, or chronic if it is more than 30 days. Prolonged we see called it as 7 to 13 days, and persistent is 14 to 29 days. There are multiple causes for acute infectious diarrhea and non-diarrheal illness. Most common viral are the causes for diarrhea. Routine investigation not required, and management is done based on the degree of dehydration. So there are multiple causes of causative agents for acute watery diarrhea, acute body diarrhea, and persistent diarrhea. Like for persistent, we have Cryptosporidium, Campylobacter salmonella. For acute body, we have Shigella, Campylobacter, enterohemorrhagic E. coli, or invasive E. coli, and others. Investigation in diarrhea includes stool microscopy, blood urine, serum electrolytes, and arterial blood gas analysis. And other tests include TLC, DLC, band cell count, ESR, and CRP. So based on the clinical signs and symptoms. Then investigation in acute diarrhea only based on indications includes blood cultures and stool cultures. Stool culture we advise only if it is a severe or persistent diarrhea, temperature of more than 38.5, bloody or mucoid diarrhea, presence of stool leukocytes, severe abdominal cramps. Then in investigation in acute and other tests include toxin difficile tests such as GDH assay, which is a screening test, then toxin assay, then modified AB staining for immunocompromised patients to rule out cyclospora, azospora, and other such pathogens, then multiplex PCR and chest X-ray based on clinical needs. Stool culture should not be done for acute gastroenteritis of shorter duration. Do not submit a specimen contaminated with urine. Send freshly passed stool sample. Do not send more than 1 stool sample per day. The maximum time to transport should be less than 2 hours. If more than 2 hours, then refrigerate the sample. Now, this is the classification of C. difficile infections. I'm not mentioning it. You can go through it to the presentation. There are different causes of C. difficile infections, which include clindamycin, ampicillin, amoxicillin, and others. There are different causative organisms. The empirical treatment and the alternative treatment I mentioned in the slides. You can go through it. Now we have the GI panel for the gastrointestinal infections, which detect 22 targets around time of 1 hour, which include different bacterial causes such as Campylobacter, C. difficile, Plasmodium, Salmonella, and others, as well as some viral causes such as adenovirus, astrovirus, norovirus, and parasites like E. storatica, Giardia lamblia. The sample type is stool sample to be collected in a Caribbean medium. Volume required is 200 microliter, and sensitivity is about 98% and specificity is about 99%. So these are the different organisms that is detected from the GI panel as compared to the stool culture and the immunoassay test and traditional PCR. The GI panel detects most of the targets or the pathogens of GI infections. It has been observed that using such syndromic testing for infectious gastroenteritis has been observed to improve the diagnostic yield and reduce the stay of the patient. However, it should be limited only for young infants or elderly patients, travelers, or immunocompromised patients. So similarly, we have joint panel for different group of pathogens for joint infections. The sample type is synovial fluid with a sensitivity specificity of about 91 and 98% respectively. So there are different such panels available for different syndromes, which can help to guide the clinicians for detecting the most relevant pathogens. Also, also there are panels which detect antimicrobial resistance genes such as ESBLs or CTXM or carbapenems such as KPC, IMPBM, MDM, and others, including beta-lactam resistant genes such as MECA genes and MRE genes. So it is very important. It is very, why should do such resistance detection early? Because it's essential to reduce the duration of the antimicrobials as well as to lessen the cost of the patients because of the antimicrobials. And there are different panels testings available such as PCR or microarray, and for different equipments like BioFire or a Gene Expert or a Luminex blood culture test. For example, if you see the KPC, where there are heterogenic activity antibiotics available, such as penicillin, narrow-spectrum cephalosporins, external spectrum cephalosporins, and others. Wherein the active antibiotics are colicin, polymyxin, tetracycline, and others. For MBL, the antibiotics include colicin, polymyxin, tetracycline, carbapenems, aztreonam, and others. So this identification of these antimicrobial resistance genes help us to understand the most active antibiotics. Hence, the importance of the syndromic panels, such as antimicrobial resistant panels, for detection of these antimicrobial resistant genes and to identify the most active antibiotics. This is one of the chart that I mentioned earlier too about the how the syndromic panels help us to identify the most relevant antimicrobial resistant genes, and accordingly, what would be the first options and the second antimicrobials for that antimicrobial resistance gene of that particular organism. Similarly, we have for Klebsiella, Pseudomonas, and others the detection of the antimicrobial resistant genes. So that was all about these different panels. Syndromic testings help us for the syndromic testing, which help us in turn for the eye doctors and the infection control team to treat more adequately the patients, protect the patient, and for the laboratory team, it helps them to detect more faster and offer services 24/7. And for the hospital, it offers better patient outcomes and savings for the patients. To summarize, syndromic testing is the need of the hour. It is fast, easy, and comprehensive. The different diagnostic methods such as syndromic multiplex panels and the microarray diagnostic methods positively impact the patients, physicians, and everyone in between. Each syndromic testing panel offers severe proven benefits and empowers the healthcare professionals to choose the right test at the first time. The key takeaway point for practice include clinical diagnosis is the starting point and most important part of the antimicrobial stewardship practice. Understanding the risk factors such as host, patient, environment is the next most important step. ICMR and other such guidelines are then available for us to pick up the most relevant possible pathogens. The local antibiogram or the ICMR antibiogram can be used as a guideline, as a guide to predict the more prevalence of AMR in the potential pathogens. Select the most appropriate antibiotics most suitable for the potential pathogens and the site of infection. So that was all about what we learned in this session about the principles of diagnostic stewardship, the elements of antimicrobial stewardship, how different syndromic panels are useful for the patient therapy.